All right, so welcome everyone. We have our 8th session today for the boosters and beyond. We're going to be talking about antipsychotic medications and behaviors as it relates to the quality measures, as well as identifying triggering residents for the measure and developing a culture to reduce antipsychotics. We'll have Dennis going to be speaking for the topic today. And as a reminder, we are the IPRO QIN-QIO. We are your quality improvement organization contracted by CMS to cover and support the 12 regions shown here. IPRO handles New York, New Jersey, and Ohio. Health-centric advisors handles Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent handles Maryland, Delaware, and District of Columbia. Together, we are 3 companies under the IPRO QIN-QIO. So if someone asks you if you've ever heard of IPRO, you say yes. And with that, I'll pass it over to Dennis.
Okay, well, hello everyone. We'd like to start all of our presentations just to talk a little bit also about the COVID-19 boosters. And the CDC does have information regarding share recommendations. I believe this is on their site where it talks you through how to encourage staff to get their booster because of course, we're entering flu season, but we still want to encourage vaccination of pneumococcal vaccines as well as COVID and COVID boosters. Next slide, please. And if I'm saying anything that's incorrect, Melanie, please jump in because you're our little expert. CDC has this vaccine confidence website where, they've got all kinds of sources and information so that you can get tools and verbiage to be able to help your staff accept the vaccine.
David. I'm going to jump in.
Please do.
So, we've recognized that building vaccine confidence is certainly an opportunity when we're talking about COVID vaccine or all vaccines. And the CDC has been putting out a lot of information. So this is a great website. Also, the share. What that is a great tool. The slide before, to train your staff to use those techniques every time they're in an opportunity to talk about vaccine. So that's on the spot how you actually approach the conversation about vaccination with whoever you're serving. It's whether you're trying to vaccinate a staff member or you're trying to vaccinate a patient or a resident. So thanks, Deanna. Sorry to interrupt.
No, I'm glad you did. Thank you. Next slide. And then Melanie and our other infection preventionist, Mary Ellen Casey, developed this fabulous immunization toolkit for influenza, pneumococcal, and COVID-19. And Melanie, would you like to tell us more about that?
This is a great resource with clickable links throughout it that really talks about why to get vaccinated, an easy tool that you could hand out to residents or family members, staff, pneumococcal, influenza, and COVID, a quick fact sheet, also clickable links to send to families, letters to families. It's really a comprehensive, easy way to look at in building your immunization campaigns.
All right. Now we can talk about the stuff that I know about. So our learning objectives are going to be to review the development and appropriate use of antipsychotics, discuss the new regulations associating with the use of antipsychotics and the diagnosis requirements in the MDS, and identify the best care practice with use of antipsychotics, as well as review some non-pharmacological intervention resources that are available. Next slide, please. As we all know, Antipsychotics are one of our quality measures that are reflected on the CASPER report. However, we would be remiss if we didn't also point out that when many times when somebody is on an antipsychotic medication, they are also, when you look down into the resident view, very often it impacts their behavior, their ADL help, their the low risk for bladder and bowel. So antipsychotics are going to impact the resident in more than just this one quality measure. So there's more than one reason to get rid of them. Next slide, please. To review our long stay quality measures, that starts at day 101. And the specific quality measures would be the long stay residents who received an antipsychotic medication and the percent of long stay residents whose behavior symptoms are affecting others. The short stay measures are residents that have been in your facility for 100 days or under. And the specific quality measure for that would be the percent of short stay residents who newly received an antipsychotic medication. Next slide, please. So first, let's take a moment to talk about antipsychotics. Historically, they were developed and evolved to treat just psychiatric disorders for bipolar, schizophrenia, and very specific psychotic disorders. And the only exclusions for the quality measure are these diagnoses: schizophrenia, Tourette's, and Huntington's. If your person does not have one of these diagnoses, they will trigger for the quality measure. Additionally, on this, CMS has seen that more individuals in long-term care are getting the diagnosis of schizophrenia and are starting to really look at that in Section I in the MDS. Because it's really not usual for a bunch of 80-year-olds to suddenly get the diagnosis of schizophrenia just to validate your use of antipsychotics. So you really need to be aware of that. And it's more important, rather than getting the diagnosis so you don't trigger the QM, to think about the medication and that antipsychotic agents were not and are not indicated for agitation control in elderly patients with dementia. The medications were originally developed. The first generation ones were developed in the 1950s. For example, Haldol. Those are the typical antipsychotics. And then your second generation antipsychotics, your atypical antipsychotics, were developed around 1975. Those are the ones like risperidone, Seroquel. Next slide, please. So while each class of antipsychotics have similar effects, they work differently in the body, and some effects will be specific to the antipsychotic class prescribed. It's really very important for the doctors to decide which medicine is appropriate for that individual. However, it's also more important to make sure that the individual symptoms are not due to an underlying medical condition, medication, substance abuse, or delirium. Antipsychotic meds started to be prescribed for individuals exhibiting behaviors related to the dementia diagnosis towards close to like 2005. Next slide, please. So in 2005, the FDA first issued that its black box warning in regard to antipsychotics. The black box warning is meant to communicate that the medicine carries serious safety risks and or dangerous side effects. The purpose is for healthcare professionals to carefully consider prescribing these meds to patients. Antipsychotic meds are associated with sedation, postural hypertension, falls, cardiac arrhythmias, pneumonia, and sudden cardiac death, especially with the elderly. So these medicines really should be ordered in very rare occasions. Next slide, please. Adding to all the confusion or the antipsychotic use is we document behaviors. And one issue with medicating an individual with dementia for documented behaviors is that the behavior is very open to interpretation by the person who's actually observing the resident. And several different staff members may describe what's being observed differently. However, words matter. So the terminology we use and who's observing and documenting, really, it varies. If a resident, say you see a resident and they're talking loudly and they're gesturing with their arms and they're pacing up and down the hall. Now, one staff member may say the resident's agitated. Someone else is saying that they're angry. Someone else is saying they're anxious and they're yelling or they're disruptive. When in fact, the resident really may just be frustrated because they can't hear and they're trying to communicate that they lost a hearing aid. Yet we're giving other terms to it and we're ordering an antipsychotic before we're drilling down to what could be a different rationale. We don't know, and each individual places different rationale and descriptors due to their life experiences or current stress or emotional status. So we need to consider that. Secondly, the causes for a resident to express behaviors or gestures are very disputed when it comes to dementia. When it comes to the cognitive decline and the changes in the brain, some researchers feel that it's biologic, that the changes are due to the changes in the brain, and that results in the problem behaviors. There's other thought processes that suggest that behaviors stem from a relationship between patients and the environment. So there's a behavior, and that's a response to a stimulus in the environment. In turn, caregivers respond to that behavior through increased attention, and then a cycle of behavior and attention develops between the patients and the caregivers. A third thought process is that there's a reduced stress threshold for people with dementia, and it reduces an individual's ability to experience environmental stimuli like sounds, and they act out. And finally, another thought process is that unmet needs are the reason for some of these expressions, like they have pain or they have to use the bathroom or they're hungry. So before we medicate an individual, we really should determine the cause of what we're seeing. The residents or patients may be attempting to communicate. We just have to learn that language and follow through. Is different seating in a quiet environment the answer? Is the resident bored and prefers interaction? Does the resident become like this at the same time every day? Next slide, please. Oh, I love the Swiss cheese model. I'm not sure if anybody's familiar with it, but James Reason developed the Swiss cheese model for quality improvement. And I thought it would be useful to use when we're discussing this topic. When we think of behaviors related to dementia or cognitive impairment, we really should think of terms of the Swiss cheese model. And before starting an antipsychotic medication, we should first consider what could be causing the expression or the behavior. I put some examples here, but if you think of each one of these slices of cheese being a different factor, make sure that you've addressed each possible slice of cheese before you've started an antipsychotic. Next slide, please. Once an antipsychotic is ordered, as always, you should refer back to the state operations manual for specifics on the regulations related to antipsychotics and what you need to do to make sure that your documentation is in fact correct. Next slide, please. So I've included here one of the tags in the state operations manual that relates to antipsychotics, but this is not the only area that antipsychotics are addressed. Here is specifically just regarding chemical restraints, and I included pages 114 to 123, so that you can refer to it for specific guidance. Next slide, Josh, please. So some of the actual guidance in the state operation manual says, number one, any medication that impacts cognition or sedates or subdues and is not an accepted standard of practice for a resident's medical or psychiatric condition may be a chemical restraint. Two, it may be a chemical restraint if there is a less restrictive alternative treatment or if the symptoms for the use has subsided. Three, is there assessment, care planning, and documentation, and is it thorough? Next slide, please. Additionally, another note from the state operations manual is that if the goal is to stabilize symptoms so the person can function at the highest level possible, and that means no symptoms, and when the medication is reduced or discontinued, the symptoms return, then reducing or eliminating the medication may be a contraindication. And this is the rationale for our gradual dose reductions. Doing the gradual dose reduction gives you evidence as to, number one, are the underlying symptoms now resolved? Or is the person's life and quality of life better with the medication because the symptoms come back when you do decrease it? Everything regarding antipsychotics must be individualized. If it is not documented why it's necessary, it is assumed to be for staff convenience. And gradual dose reductions must be done to document that symptoms occur without the med and the individual is better with the med. Next slide, please. So the clinical record must show documentation that the resident or patient has been addressed and underlying medical issues have been ruled out or identified and treated. Some examples were discussed with the Swiss cheese slide, but I've listed some others here. So if you have a larger population of residents or patients with cognitive impairment, it may be beneficial to maybe place them together in the same unit or hall and alter the environment to meet their needs. At the end of the presentation, I'm going to provide some resources for non-medication management. However, there's a lot of information available regarding what environment is most suitable, how environmental changes at certain times of the day is beneficial. Even things like when your caregivers go into someone's room, singing before starting or humming before you start giving care, it triggers the happy part of the limbic system rather than the fight or flight part of the limbic system. That may minimize, some of your expressions and the natural startle reflex that we think of as behaviors. Next slide, please. So it's important that you check with your state regulations regarding, exits and egress. Check with your state regulations regarding what is and isn't allowed. However, I just put in a couple pictures of environments that have been altered for people with cognitive impairment. And some other thoughts are like, make sure chairs stand out so they can be seen. How often do we see someone with poor vision or cognitive impairment go to sit down, but they don't realize that the arm of the chair is right there. So they sit on the arm of the chair because it doesn't really stand out. Floor colors should be consistent because the treads or a pattern makes them uncomfortable and they think they're going to fall or there's a hole. Use tablecloths to reduce noise in the dining room and with colored plates so they can see the contrast, or a colored tablecloth with white plates, and that also reduces the noise in the dining room. Murals or activities on the walls so that when they're walking For exercise, they also have things to do to keep themselves occupied. Make the environment home-like and familiar. Use baby dolls, laundry baskets, utilize a resident's history if they were a nurse, ask them if they can help with documentation. One of the best things to do is say, could you help me with something? Because everybody wants to have a purpose. So could you help me fold my laundry? Could you help me with the charting? If he was a scholar or a teacher, would you help me grade some papers? And just some random papers, and let them feel that they're helping and giving them a task. Next slide, please. If an individual is on an antipsychotic and it's time for their MDS, there have been updates in July of 2022. It's very important your MDS person looks at the manual pages in the RAI for I-12 and I-16. There's clarification for the need for a detailed evaluation and appropriate diagnostic information to support a diagnosis prior to coding the MDS and steps for potential misdiagnosis. I put the pages there, but understanding the RAI guidelines relating to coding is vital. And as I mentioned before, an increased trend on some of the exclusionary diagnoses is being noted. You can't just add a diagnosis to satisfy the quality measure. Next slide, please. Again, in visualizing that Swiss cheese model, if a patient or resident is appropriate for an antipsychotic, our duty is to prevent harm. So we've determined that they need an antipsychotic and it's the best thing for them. Our next task is we need to make sure that they are safe. There are regulations and standards that are in place to try and assist with the prevention of harm or side effects. It's also important that individualized care plans for medication use with approaches to care and non-medication interventions are used. Resident or patient is monitored for distress. Benefit outweighs the risks. The signs and symptoms are clinically significant enough to warrant medication use, and that the pharmacist medication review is thorough. With any change in the status of a resident, you should also review the need for the medication. As the disease progresses, they may not need it any further. If they, you don't know. Next slide, please. Further review. Focus areas should include the acceptable clinical indication for use, the diagnosed condition, so it's stated and documented, it's not for convenience. Effectiveness is monitored. What exactly is the goal of the medication use? Monitor for changes that may be due to medication use. Monitor for potential adverse consequences. Ensure appropriate dose and duration. Ensure gradual dose reduction is done as required and documented and is thorough and easily found in the medical record. And make sure that there's non-pharmacological interventions used and documented. Next slide, please. As I said, I was going to include some websites and resources for non-medication interventions. So AHRQ has some great resources available for you to implement. So does IHI. They have the age-friendly systems and the 4Ms. You can go to dementia.org or the Alzheimer's Association to determine different ways to treat behavioral symptoms due to brain changes related to dementia, and interventions that can be used. Next slide, please. Just this week, an article came out in McKnight's Long-Term Care magazine that did say that even though in skilled nursing facilities, we are starting to pay more attention to antipsychotics, the federal government and surveyors are seeing that there is a rise in antipsychotic dosing and use in assisted living. So if you have a campus with joint buildings, that's something that, you know, you might want to pass on. Or when you get new residents, every resident, of course, should be evaluated for antipsychotic use, but especially those residents in assisted living are getting those prescriptions more often. Next slide, please. iPro has developed a template antipsychotic action plan for reduction, and we're working with one facility right now to help them reduce the numbers of antipsychotics in their facility and work through gradual dose reductions. If you're interested in that action plan, reach out to one of us and we can get it for you, and we'll put it up on the resource library shortly. But we, you know, did put together a action plan or a quality improvement plan so to help facilities with this reduction initiative.
Janice,
So,
I
yes,
added a question. I added a question because there's so many attendees that maybe they would like to share. Do you have unique methods
that
of
would be wonderful.
non-pharmacological interventions? Share with your peers.
What's everybody doing instead of medicating?
I know one facility I worked at, we we actually developed a quiet room, and for those that really everything was calming in there, and those folks that really had struggles when other residents were getting worked up, we could bring them in there. Quiet music, quiet videos. We there was a relaxation chair, so a variety of different things. Oh, we're getting
Music
some
therapy.
yeah. I think music therapy is a great option for many residents. The headphones kind of turns the noise
Off,
down. For other
yes.
people. Yeah. Please
So-
keep adding some of your interventions.
Yeah, Melanie, I really appreciate this conversation because even from working with facilities and speaking with many directors of nursing and administrators, a lot of facilities sort of go through the process of a gradual dose reduction without putting a lot of systems in place. So they try to reduce the antipsychotic medications and then it fails. And then they said, see, we need it. But they never really actually put like a lot of things in place. You know, like first lines of defense where, you know, everyone there's like shared compelling message across the whole facility why we want to avoid using these medications. They're not putting the therapeutic environments in place. They're not having staff be able to demonstrate different types of competencies in identifying and addressing, you know, behaviors, or not even, you know, looking at the hospital transition process. You know, they just send someone out just like, there's I'm going to put in chat, there is this really great toolkit that goes through all these different steps that you should identify and address before you even start to start that gradual dose reduction so that it could become more effective. So while I'm getting that chat, get that link to put into chat, would appreciate everyone else chiming in, or you guys, I think a lot's coming in. So
Yeah.
but I'll pass it back to you guys while I get that link for everybody.
No, it seems like everybody's on the same page that we need to start, you know, minimizing the use of these meds and doing other interventions.
I think it's a great point, though. Individualized care plans go a long way. It's so important to make sure that you're expressing, and in your care plan, it does make sense for this resident, because we all know the staffing challenges you all are facing. So if you have a new CNA doesn't know the resident's dealing with new faces, new voices, still the masks, and the CNA does not know how to touch and reach out to that person. Those care plans are so important. And I want to know what body socks are.
They're flexible polyester, elastic, whatever, sleeping bags, and it gives a person resistance in their movements, help tactile issues and anxiety, kind of like maybe a weighted blanket.
Yeah, the weighted blankets I've seen work really well.
Yes, they're
Also reduce
wonderful.
falls. Yeah.
I've also seen the tiny Dove chocolates. One of our psychiatrists ordered tiny Dove chocolates 15 to 20 minutes before someone had a shower, and that chocolate would help the download, or whatever, of serotonin, and then eventually the person, so them getting in the shower 20 minutes later was not as traumatic, and the nurse would sign out the chocolate on the MAR and it was kept in the med cart, and we were able to reduce the medication by giving them this piece of Dove chocolate 15 minutes before every shower, because they had this serotonin. It's all about brain chemicals and getting one part of the limbic system versus the other one engaged.
And it's another thing that's showing up in the chat is that quite a few different people are saying to involve the nursing assistants, that they're actually the ones who would know what worked the best when they're developing the plan of care to help for reducing.
Absolutely.
Yeah, when I was managing a building as an administrator, I had a resident who was nonverbal but could still communicate in different types of ways, and that the CNA who was on consistent assignment to take care of that resident could understand like a totally different language with what the resident was saying with them, and that is really so important to your success of working with your residents and providing great dementia care.
Another thing we did was for showers, we would go in and instead of saying it's your shower day, say your son ordered a spa day for you. So now I'm not a stranger. Now there's a reason for me to see you naked. Again, it's giving you a nice feeling. Oh, a spa day. Oh. And some family members would bring in a towel or something from home, so there'd be that smell of home.
Yeah, that's another great point too. Like the different sensory things. I one facility I had seen had like a baking activity where they would bake like fresh bread and fresh coffee, just stimulate the residents, which was really amazing. So I wanted to share two. I put the links in that I mentioned about the toolkit for the dementia care change package, about going through all those different items before we even attempt that gradual dose reduction. It was something that Maine, the state of Maine, did as sort of like a statewide action plan. So even though was developed in Maine, there's a lot of great principles and lessons to be utilized from this change package. So I really encourage you all to take a look at this and take a look at the things that you should be addressing before you even attempt those gradual dose reductions.
And I just want to say there's a lot of questions about weighted blankets and the body socks being restraints. I would say as you look at all restraints, identify it, look at it, see if it would function for that resident. I mean, you can put a bet against a wall based on that individual resident. So you're going to look at every situation when it comes to a potential restraint based on that resident and use your protocols, your policies, and your federal and state regs.
Exactly. Care planning is key. Theoretically, putting somebody in a recliner with their legs up could be a restraint if they can't put the legs down, unless you care plan for a certain amount of time due to edema or whatever. So yeah, care plan and look at your regs and make sure it's individualized. And that everyone on your floor, all your staff understand why that resident is there.
So that was it for our formal part of the presentation. Do we have any other questions before we end the session for today?
I just wanted to mention my name is Idria. I work at Butler Hospital. And one thing that we implemented about 7 years ago now is a round-in program. And the purpose of that is for the staff to meet patients' needs before they become acute, because we know that patients with dementia, once they have needs that are unmet, the way their behaviors become exacerbated.
Mhm.
So by meeting their needs proactively, we were able to reduce. We actually started this program in a way to meet needs of patients who are higher functioning, who kind of felt left out because the patients who were less functioning required so much assistance from staff. That was the original reason we implemented this program. It gave an opportunity for staff to make sure that they were also checking in with our higher functioning patients. And actually, as a result, we ended up reducing falls and use of PRN medications.
That's wonderful.
Adriella, love to hear more about that. If you can contact us with, I can put my contact information in here.
Okay.
There's also, I mean, there's a woman named Teepa Snow, and she's a dementia educator, and she's got, 10 to 20-minute YouTube videos that you can view. I mean, there's so much information out there that we just have to, step out of the box of medication and try new things and involve the family. They may know things that we have no idea about.
So I know we're getting really down to the wire. We would love to hear if this QI series has been beneficial and how it's supported your facilities. It's important for us to get the feedback, so you can put it in chat. You can send us emails. We love to hear if what our programming is effective in helping. So please go ahead and put that in chat or send us emails. And I think Josh just answered the question. The slides in the presentation will be available once it's 508 compliant on our webpage. It's going to be enhanced barrier precautions because there was changes in July. So come and chat with us.
And if you need assistance starting an action plan, reach out to us. We're all passionate about all of this, so we'd be more than happy to help you guys figure out, actions, steps and everything.
Yep, and I just put the link again to the change package for the dementia care change package that they initiated in Maine. All right, and with that, we'll end the call for today. Thank you so much for everyone joining. Thank you, Janice, for presenting, and I appreciate all of you contributing to the discussion. These sessions are really designed for you, so they're better when you bring questions and contribute to the conversation. And of course, we appreciate all feedback for these sessions. Thank you so much.